All right, this will be part 2 to Chapter 17. We're going to finish up talking about some shock management and then work our way into cardiac arrest management. So we have a couple of still hot topics to complete here. What I ended with the last lecture when I ran out of time, we were still talking about the tourniquet. Of course, most of you probably learned in your EMT class the basically the old-fashioned windlass and cravat method, and that still works. It's still tried and true. It's not quite as quick, but it does work. A lot of agencies are still relying on that. Tourniquets are still, really slowly working their way back to the world of EMS. The military's used them for a long time, but in the world of civilian EMS, we're still kind of cautious on going that route. So I will point out, though, that what we commonly call a tourniquet in EMS when we're starting IVs is not really a tourniquet. And a tourniquet is something that occludes arterial blood flow. There are other people who will say, well, if we're going to do tourniquet, why don't we just use a blood pressure cuff? And I think I've mentioned that before with pressure dressings, that most of the time they leak. They're just not reliable enough. So using either the old-fashioned cravat stick windlass method or one of these commercial ones, and this one actually I remembered is called the MAT, Mechanical Advantage Tourniquet. And it works pretty nicely. The other one that we talked about, the CAT tourniquet, combat tourniquet that the military uses on a very regular basis, are probably our two most common commercial tourniquets that are on the market today. There are other things out there, and I'm not going to say that they're not worth using, but I would say definitely use some buyer beware when you come to some of those things. I imagine we're going to see more and more of them because they've been proven. And in the old days, we used to believe that if we put a tourniquet on you, we had an hour or two to save a limb, or otherwise it was going to have to be amputated, and nobody wanted amputated limbs, so they really discouraged tourniquets. Well, in this day and age, with more and more science and more military experience being added to it, we're actually starting to see that 8, 10, 12 hours with the tourniquet on is not going to affect the outcome. The one thing that I do need to throw at you, though, is when you put a tourniquet on somebody and you put the tourniquet on them correctly and the blood flow is stopped, that person is going to have a lot of pain. It is just not comfortable. So when you're doing tourniquets, you're probably going to want to be thinking about a little bit of pain control. Maybe if the patient's conscious enough, we can allow them to use a little nitrous oxide. Remember, that's basically self-administered, so when they've had enough, they quit. But rapid transport to the hospital, get them or get some paramedics there so that they can provide a little bit of other analgesia will be probably very welcome by that patient. So let's see, anything else on tourniquets? So if you haven't used haven't tried and practiced the old style method, we'll definitely probably be working on that in the skills day coming up, as well as maybe looking at a commercial version or two of some of these tourniquets. So. All right, so bleeding severe, it's ongoing despite doing direct pressure, doing some, not elevation, doing some pressure dressings, splinting, of course. We can consider going to tourniquet. It's most of the time used for arterial flow, but it's a wide band that constricts both the venous and the arterial flow. Obviously, if it constricts the arterial flow, it constricts the venous flow. But this wide band, you got to remember, it needs to remain at least probably closer to 2 inches or more wide in order to prevent actually cutting into the patient's tissues. If you would use like a wire or a string with the intent of using that as a tourniquet, you actually are just going to cut into the tissue and not get the wide pressure that will be applied to that artery. So, used to control bleeding from any extremity by placing the tourniquet between the wound and the heart. They say usually if you can, move up beyond the next major bony prominence. So if we had a forearm injury, we would probably want to go just below the bicep and above the AC. That's probably the more highly recommended. If you got something towards the elbow or towards the upper arm, you want to maybe work your way up all the way to the right below the shoulder, and would be the best places to put those. Obviously, we cannot use a tourniquet on the patient's neck to control bleeding in the head, simply for the fact that if we cut off blood flow to the brain, the rest of it really doesn't matter. So, and it's not appropriate for all sources of life-threatening bleeding. So, for example, an arterial bleed, I've had a couple patients had weird bleeds. One person lacerated a temporal artery, which is just above and in front of your ear, and a tourniquet would not obviously be appropriate for that person. So, also, we can't tourniquet things on the inside. We don't have that capability. So, do not cover it with bandages or clothing. Of course, if you throw a blanket on them, that should make it fairly visible that when they pull back the blanket, they should be able to see it. Most of the civilian versions of these tourniquets, these commercial tourniquets, come in a bright orange color. The police versions, the tactical versions, as well as the military versions, they have some black and some olive drab colored versions of those that don't draw as much attention to them. And I know that the CAT tourniquet, the training version of the CAT tourniquet, is blue. So it makes it a little more obvious that, hey, this is for training purposes. But that the bright orange tourniquets that we use in the field most of the time are going to be purposefully bright colored so people will see them. Remember, you still need to make people very well aware that this tourniquet is in place. It is still a recommendation that you take a pen and you write on the patient's forehead TK and then the time, and that will draw people's attention to, hey, there's a tourniquet somewhere on this person. We better go looking for it. So the patient's life takes precedence over the potential damage to the limb, and that's why tourniquets are brought back. It's because if we run out of blood, the patient dies. If they end up having to cut that limb off, yeah, that sucks, but we saved their life. Again, painful. Transport patients who have tourniquet to the highest level trauma center available. Reattachment, if you have something that needs reattached from a amputation, of course, bringing that along. The higher the facility you bring that person to, the greater chance they're going to have to do some reattachment. A word on elevation and arterial pressure points. I've kind of alluded to this along the last several lectures and talked about pressure points is out. We just aren't good at it. We can't do it very well, and we can't do it consistently. Elevating the extremity, it's not really, there's no science that backs it up. It's all theory that backs up. Elevating the extremity makes gravity have to work with you to reduce bleeding. And again, like in theory, yes, but the problem with this is that a lot of times the patient also has an extremity injury, and that patient's extremity injury can be aggravated by using some elevation. We can also have aggravating the injury itself, which causes excessive bleeding. So we can either do damage to, say, the broken bone, or the broken bone can actually do some more damage onto the bleeding wound. So elevation is really kind of out. If you had an extremity you absolutely knew wasn't injured beyond this, just plain old laceration, It's not going to hurt, but it really may not help. So there's just nothing to back it up. All right, and then with elevation, it can detract from application of other important measures. If you have to have one person standing there holding that person's arm, you lose a set of hands to do something else. So follow protocols. Protocols pretty much have evolved in most cases to say no more pressure points, but elevation is okay when as needed. So we talk about a little IV access and fluid administration. We've got to carefully consider fluid administration for the patient in hemorrhagic shock. Plasma is not simply water. Plasma is more albumin. So if you want to have an example of plasma, go crack an egg carefully and remove the yolk, and what's left, the uncooked egg white, is albumin. And so that's actually a closer approximation to blood than is salt water. So it's thicker. It's got a thicker viscosity. It has some proteins in it, and it has a few other little nutrients in it. So that's a good guesstimation. So simply putting water and salt into their vessels does not transport blood. I'm sorry, does not transport oxygen. You have to have the red blood cells in there to transport the oxygen. So when we do IV fluids, what we're doing is diluting whatever's left. So the rest of the red cells, white cells, and platelets are just getting diluted. What's not lost. So blood is going to lose its oncotic pressure and cannot effectively maintain an intravascular volume. So as we change the concentration of what's actually floating around in their vessels. So let's stop for a moment and think about this. Roughly 45% of your blood is red blood cells. So if we've lost a bunch of red blood cells, so let's say we've lost 25% of our red blood cells, then that's going to change obviously the number of red cells we have. If we replace simply the fluid, so let me give you a little different example here. Let's say you have 6 liters of blood in your body. You lose 2 liters of blood, so you've lost a third. So you've also lost a third of your red cells. In theory, you've lost a third of your red cells. So if you had 45% of the red cells, you had 45% of your blood was red cells before, we still have 45% of our blood being red cells after, but the whole concentration, or the whole total amount, is down. So if we refill just the fluid, we're now dealing with only 30% of the red cells we would have, even though the container has the whole 6 liters of fluid left in it. So because we didn't replace any red cells, all we did was replace volume. So we're running with a third less red cells than we normally would. So that concentration change, we now have a lot more space in between red blood cells. It changes the oncotic pressure, so it's going to change the way that fluid behaves in the vessels. The clotting factors are also needed to help stop the bleeding, and those also have been diluted. So everything gets diluted when we add fluid. If we add 200 cc's of fluid to our 6,000 cc's, 5,000, 6,000, depending on your size, we add 200 cc's. That's not a big deal. That's a drop in the bucket. But if we've lost 2,000 and we add 2,000, now we've really changed the dynamics. So intravenous access and fluid administration can raise the blood pressure, but it cannot solve the underlying problem of cellular ischemia and acidosis. It may temporarily patch it because it now allows blood to fill all of the cracks and crevices that it's supposed to. But remember, we only have X amount of the percent that we normally have. So we increase the blood pressure, but it also dilutes the clotting factors, it dilutes the platelets, it dilutes the red cells, it dilutes the white cells. So this can actually increase bleeding because the pressure goes up, but we don't have the clotting factors and the platelets to go along with. it can also make the patient hypothermic, particularly in the wintertime. So we have cold patients, we give them cold room temperature fluid because it sat in our ambulance station, which probably wasn't really well heated to begin with. We maybe didn't have an IV warmer, and you can buy those. They're a couple $100, so if you got money on your service eating a hole in your pocket, buy an IV fluid warmer. So it wasn't in a warmer, sitting in an ambulance that was, we'll say 60 degrees or whatever. 60 degrees and 98.6 degrees are a long ways apart. So 2 or 3 or 4 liters of fluid dumped into a patient is going to pull that temperature, body temperature, because our blood does a lot to maintain our body temperature, is going to pull that body temperature down. So IV fluids lower that temperature, and it really taxes the metabolism even more. So now the metabolism's like, not only am I losing blood, not only am I having to work hard to oxygenate and get sugar to where it needs to go and take away the waste, but now I also have to warm the whole body back up. Holy crap. So it just adds more to the overall workload of the body. So IV access and fluid administration, any patient with internal bleeding in a pre-hospital setting has uncontrollable bleeding. We should consider it, but again, we are going to be much more concerned with trying to control the bleeding when possible. Internal bleeding is a little harder for us to control, so we give them some fluids because if they start to bleed out, they can kind of start to tamponade themselves a little bit. So if you have that patient that's bleeding into their gut, eventually they may start to get some pressure pushback from whatever's in their gut. External bleeding, we're going to infuse IV fluids to increase the blood pressure to close to normal and maintain it. So these are those patients that is probably, let's start an IV, let's use a big dog catheter, an 18, 16, maybe a 14 when we can, as opposed to a 20 or a 22, and have it available in case we need to give them a little bit. We do have a concept we use in EMS called permissive hypotension, and this is the balance between maintaining the level of perfusion without worsening the situation through excessive fluid administration. So when we're talking about this concept of permissive hypotension, basically we're looking at, and I'll direct your attention to the bottom of 433 in the first column, a typical target systolic blood pressure in the shock patient somewhere around 80 to 90 millimeters of mercury. No, it's not optimal, but it's enough to keep the brain, the heart, the lungs, the liver, the kidneys going. So a lot of times we can do somewhere from around 500 cc's of fluid will give us a nice little boost. We'll refer to these as fluid challenges or fluid boluses. So starting with 250 or 500 cc's, see how it goes. When you do that, you're going to want to consider re-listening to the lung sounds on a regular basis. If we have a patient who has congestive heart failure and we give them too much fluid, what happens is it floods their body. So they get their body flooded and they no longer can keep up, and it actually starts to invade their lungs and cause pulmonary edema. So in patients with hemorrhagic shock and traumatic brain injury with a suspected increased intracranial pressure, so meaning that you think they're bleeding into their brain, then the mean arterial pressure needs to exceed the intracranial pressure sufficiently to allow cerebral perfusion. So in those cases we actually will bump up to a 90 to a 100 millimeters of mercury range, simply because we have to balance out a little extra pressure in the skull with a little extra pressure in the system. So that's permissive hypotension, kind of an important concept. And there we go again. So systolic blood pressure in a patient with ongoing bleeding, 80 to 90 millimeters of mercury. Hemorrhagic shock and TBI, 90 to 100 millimeters of mercury. Fluid resuscitation in the non-hemorrhagic shock patient. So shock is best treated by reversing the underlying cause, and so knowing the differences in our different pathophysiologies of shock will help us. Some of these things we have mechanisms to try to correct, others we do not. So if we look at something like septic or anaphylactic shock, they're distributive. They have quote-unquote a hypovolemic component. In anaphylactic shock, we can give this person some epinephrine, and that's going to cause some vasoconstriction. That's going to help adjust. It's going to help constrict and cause the patient to bounce out of that. Remember, this lasts all of about 10 minutes, though. So one dose of epinephrine is not, go get the tough book, let's sign this patient off. They can go to the hospital themselves because they're going to take a crap here very, very soon. So anaphylaxis, we definitely have something we can treat. With sepsis, even at the paramedic level, we don't have much to treat a septic shock patient. We're going to give them fluids. We're probably also going to give them another drug called dopamine. And dopamine is a pressor agent. It does a better job of constricting the vessels than epinephrine does. But again, it is a kind of an ugly, nasty drug. So it's not easy on the body. So, and dopamine does not always work. So we have that patient with septic shock. They are going to be dehydrated, so some fluid is helpful to them. Patients with cardiogenic shock, though, if they have cardiogenic shock and we start to flood them with fluid, we're going to cause them to have an increase in pulmonary edema, and we're going to cause an even bigger problem. So we have the potential to cause them to go into arrest. Fluid resuscitation in the cardiogenic shock patient is you have to be very, very careful. And again, this would be give them a couple, maybe 100 or 200 cc's, see if it changes their lung sounds, see if they change their ability to breathe, and if they do, hold off on the rest of the fluid. It's definitely get the paramedics there. Dopamine is particularly indicated in cardiogenic shock, so getting the paramedics there. Almost all paramedic ambulances have dopamine, so it has a great potential here. In obstructive shock, the fluids can increase the preload and increase cardiac output and blood pressure, so it can be helpful, but we're not talking liters upon liters. We used to have a rule when we gave patients fluid in shock that we would give them 2 to 3 liters for every 1 liter we suspected they had lost. Well, that very easily goes overboard very quickly because now all we have is pink Kool-Aid running around in their veins. And that doesn't do anything. It doesn't work. So again, that permissive hypotension in our hypovolemic patients, and then carefully monitoring our patients in our non-hypovolemic shock patients as we give them fluid. So obstructive shock's probably okay. Distributive shock's going to be all right in most cases. Cardiogenic shock, not so much. MAST pants, or PASG. MAST is medical anti-shock trouser, or PASG is pneumatic anti-shock garment. Most of us that are old school EMTs, we learned a lot about MAST pants. We do a lot of practice with MAST pants. They really have fallen out of favor. MAST remains a it really remains a controversial piece of equipment. It is still recommended for patients, say, with a lot of lower extremity trauma that we need to do some splinting, basically using them like a very, very big air splint. But it can complicate some problems. So application can interfere with some of the treatments that we've done. You put MAST pants on a patient with cardiogenic shock, you're going to probably kill them. That's the one contraindication, is a patient with pulmonary edema of cardiac origin is an absolute contraindication. The rest of them are kind of relative. So if you have something impaled in the abdomen, you can put it on and pump up the legs only. If you had something impaled in one leg, you could put it on the other leg and pump up just one leg. You can never pump up the abdomen before the legs. You either pump them up simultaneously or legs first. But there are some other things that people will discuss, whether or not they're appropriate for head injuries because it causes an increase in intracranial pressure. There is definitely a right and a wrong way to use these things. So it's something we'll want to take a closer look at as we progress through class and in skills day. and maybe practice with these just a little bit. Right now, again, they're not highly favored for shock, but your protocol might dictate using them. All right, so these the think about it's. This patient has joined the gym a few weeks ago to train for an upcoming marathon. Has not worked out regularly for several years and is obese. Despite being cautioned by his assigned personal trainer, he has been working out too hard for his current fitness level. Today, after about 10 minutes on the treadmill, he suddenly collapsed, and another gym member called out for help, found that Mr. Cutler was unresponsive and was making gasping attempts at breathing. The two gym employees arrived within seconds, and an AED and another one called 911. So basically, kind of going along with your case study in the book there, it's really a continuation from the front. So we'll let you kind of look at your problem-solving questions to go along with that. And we'll move ourselves from shock into cardiac arrest. All right, so I mentioned previously cardiac arrest is the ultimate shock, basically. You instantly have cessation of circulation and almost immediately have the cessation of the respiratory drive. So the primary cause is usually an acute coronary syndrome or a different cardiac dysrhythmia, meaning that most of the time when a person arrests, it's actually a heart-related issue. However, in children, the typical result is respiratory failure. So the heart, typical in the adults, and it's actually becoming a problem younger and younger and younger in life now. The heart develops a dysrhythmia. It doesn't produce a mechanical contraction sufficient to generate a cardiac output. So basically what it does is the heart starts to squirm in the heart rhythm, ventricular fibrillation, and I'll draw your, they don't show it off. Oh, there they do. If you look at picture on 435 in your text, picture A is ventricular fibrillation or VFib, and that's electrical chaos within the heart. So nothing's going on in sequence, so the heart just quivers. Basically, if you bought 3 dozen night crawlers, put them in a sandwich bag, and zipped it up, and then laid it on the counter, you would just see it will squirm, and that's what the heart is doing when it's in VFib. There's no nice rhythmic contraction like we're all used to seeing. So we also have a couple other tracings shown on the page there. Cardiac asystole, and that asystole means it is an electrical standstill. There's nothing going on there. Most patients don't go immediately into asystole. Most of them are found in either VFib or the third picture, which is VTAC, pulsus ventricular tachycardia. VTAC can or cannot have a pulse. It depends. Most of the time, if the patient does have a pulse, it's not for very long. VTAC is basically a person has had one particular part of their heart, usually a cell or two, has kind of overridden the whole system. So he's done a hostile takeover of the heart, and that's where VTAC comes from. Usually the heart not beating how it's supposed to. It actually, the electrical impulse goes from the bottom up. It doesn't allow the heart to efficiently pump. So there are other rhythms. There are a lot of other rhythms. We will probably do a little chat from time to time on rhythms. This is by no means is an exhaustive and extensive look at these rhythms, but if you look at Appendix 2 in your textbook, which should start on page 1079, it shows you the different rhythms. It tells you about their different characteristics. You are not allowed to interpret rhythms, but it's kind of nice when we maybe throw a term out, you can see what that actually kind of looks like. Normal sinus rhythm, which I think is the first one that they hit. I prefer to call it regular sinus rhythm. I don't like to use the word normal because normal is different from person to person. So, but to look at some of these rhythms, if we would look at, yep, on page 1082, the first rhythm they have is a normal sinus rhythm. And that's what textbook is, how a normal person's heart should look electrically. All right, there's a cardiac arrest video that you can watch on it. Talks about a little bit more cardiac arrest. When perfusion ceases, the patient becomes pulseless, unresponsive, and apneic because it stops right now, and that patient loses the oxygenation. They lose the sugar. They lose the ability to transport their waste away. So it is normally a pulseless ventricular rhythm, whether that's VFib or VTach, or it's asystole, and they list one more there, pulseless electrical activity. The thing about pulseless electrical activity is it's not technically a rhythm. Pulseless electrical activity means there's electricity on the screen, there's electricity pulsing through the heart, but there's no muscle that coincides with that. So the way that I like to demonstrate this is if I would hold up a lamp that you can't see where the cord is plugged into, where the plug's at. If I hold up a lamp, can you tell me whether or not it works? If it's not lit up, can you tell me if that lamp works? You can't. Okay, if I click the switch and turn the lamp on and it doesn't light up, can you tell me what the problem is? Well, it's got to be one of two things. Either there's not A, electricity going to the bulb, or B, a filament in the bulb that's able to do the work that the electricity makes it do. So you have to have both parts. You can have electricity coursing through your lamp, but the bulb is burned out. And that's what PEA is. Pulseless electrical activity is the bulb's burned out, or the muscle, the heart, is not functioning. So we might have a bulb that works but no electricity, and when we have a bulb that works but no electricity, that could be early in cardiac arrest. When we have VFib, we technically have electricity, but the problem is the electricity doesn't go in sequence like we need it to. So the body tissues and the organ systems will rapidly become damaged from that lack of perfusion. Cellular death begins in 4 to 6 minutes. If perfusion is not restored within about 8 to 10 minutes, then permanent death or biological death can occur. So you are clinically dead if you have no pulse. If you have no pulse or you have no brain electrical activity, you can be considered clinically dead. Without any brain electrical activity, that's called brain death, but you are not biologically dead until you are irreversibly dead. So that's usually in about that 8 to 10 minutes beyond your clinical death. So after 10 minutes, most of these cells have really fallen apart, and there's nothing left for them to continue to function. So starting CPR early is what buys us that extra time. If a person laid there on the ground for 15 minutes before an ambulance showed up and nobody did anything, that person's dead. Unless they're extremely hypothermic, that person's going to be dead. There's nothing we can do about that. So it's too much time had gone by. So the chain of survival, we hear about the chain of survival from time to time. The chain of survival really was started kind of by the American Heart Association, and it started actually with 4 links. The first 4 being immediate recognition of the cardiac arrest, activation of the emergency medical services system or emergency response system, including early CPR being the next link, and then the third link being rapid defibrillation, hence the reason why we see so many AEDs out in the world now. Fourth is early advanced life support, whether that's paramedics or advanced EMTs or doctors and nurses. And then finally, the 5th one is integrated post-cardiac arrest care, which is, I've mentioned before, has kind of been a forgotten about component to this whole thing. But so we have to see that somebody's gone down. We have to have somebody recognize, hey, there's an issue here. If nobody recognizes it because this guy's been laying on the bench every day for the last 3 years because he's homeless, and somebody drives by and he's still laying on the bench, it's pretty doubtful that anybody's going to do anything about it. with when things are out of the ordinary, somebody's paying attention and they notice it, somebody falls down right in front of us, goes unresponsive, that actually becomes a quickly noted thing, and people get a little bit more, charged up about it. So they get a little bit more fired up and start to want to do something. Activating the emergency response system, this can be in a variety of ways, whether we're talking things like medical alerts, maybe it's calling 911, maybe it's calling the emergency number within the facility that you're in. So activating the system, getting some help coming. Doing early CPR with an emphasis on chest compressions. This early CPR, that's why they really push it in the schools these days. Both Iowa and Nebraska have rules that require it now in the schools. They want parents to learn it. They really want people to get on pushing on the chest. Even if they're pushing on the chest for 4 or 5 minutes without even doing ventilations, there's still some oxygenation moving around. There's still some perfusion occurring, some waste getting carried away. It's not perfect, and after several minutes of doing it without any breathing, then it's going to really lose its effectiveness. But to get started is at least buying time. CPR is really about 30 to 40% as effective, so a third as effective as your heart actually pumping. So even at our best, we have a hard time doing near the quality that your heart actually does. There's been some emphasis recently on using automated CPR devices. The jury is actually still out. There's scientific data that's kind of inconclusive on it. The keepers of the science is the American Heart Association, and they're saying just routine changing of rescuers. So every 2 minutes, switch compressors. So a fresh person is on there, somebody gets to rest, and that keeps the quality of the CPR up. They'll tell you that there's lots of data that supports using automated CPR devices. Automated CPR devices are good for a couple things. Number one, it frees up a set of hands, and number two, it does give you some consistency, but there are drawbacks with it. Number one, most of the science that gets cited by this stuff was studies that was actually done by the manufacturers. And what do manufacturers want to do? They want to sell stuff. They want to make money. So the other thing is they're not one size fits all. They require a lot of resources to get going. They're expensive, and we can go on and on and on. If you have one, great. I hope you're good at using it, because CPR gets lost for minutes at times when we're worried about dinking around putting on the Lucas or the auto pulse or the thumper or whatever. So you need to be able to do it efficiently and not interrupt chest compressions to do it. So chest compressions are very, very important. We've got to keep them going almost constantly. Really, in all reality, when we're getting ready to do defibrillation, the only time we should be off of the chest, not pushing on the chest, is when it is analyzing and when it's actually delivering a shock. So if you have a newer AED that charges up and delivers a shock within 10, 15, 20 seconds at the most after analyzing, you stay off the chest. But if it's going to take more than 20, 30 seconds to charge, get back on the chest, push on the chest until it is fully charged. Everybody gets clear, deliver the shock, and we're right back on the chest. So it takes roughly 5 to 8 compressions to get the blood actually started to pump again, because it has to prime the pump and build the pressure. So constantly compressing keeps that pressure up, so you don't have to constantly reprime. And so doing 30 compressions, it takes 5, 8 compressions to get the pump primed, so we get roughly 20 compressions, 20, 25 compressions that are actually worth a hoot to move any blood. So So when we move to defibrillation, the AED and then the advanced life support, so getting the AED on board, you guys will still use an AED in your system as advanced EMTs. Advanced EMTs do not do manual defibrillation like paramedics. The AED is become an incredibly useful piece of equipment for us in EMS. It takes a lot of guesswork out. It's not that it is foolproof, but it's not easy to fool either. So as long as you kind of stand by your standard techniques and protocols, you stop the ambulance as necessary to analyze and to deliver shocks. It does not come without danger. It is a device that is powerful enough to save your life and to take your life. So the early advanced life support comes in with the either manual defibrillators and or drugs and or further advanced airway care. So AEMTs kind of straddle this. AEMTs can use the combi tube where EMTs really don't anymore, and can start some IVs. Paramedics bring the drugs and the manual defibrillation, so as well as the ability to interpret the cardiac rhythms. And then we bring them to the ER, and the ER adds a couple bit more little things to the mix. But in reality, ERs don't do a heck of a lot more in most cases than paramedics do when it comes to cardiac arrest. There's just not a lot of more, unless there's a perfectly identifiable cause, there's not a lot of extra things that can be brought to it. When it comes to trying to resuscitate, most of the time at the paramedic level or the standard ER level, that's about as good as it's going to get. And then integrated post-cardiac arrest care is huge. Hypothermia, there is science that says that once we resuscitate a patient, if they don't immediately wake up, we make them cold. So if you get hypothermia protocols in place, you start cooling them by putting some ice packs in their pits and around their neck and in their groin. There are other devices. There's cold saline we'll put into patients. There's some cooling blankets, some cooling lavages and stuff, and that helps. It's like steak. You take a steak, you throw it out on the counter, and you leave it there for 4 days. It's not going to be any good by the time you get to it. But you put it in the refrigerator for 4 days, it's going to be in very good shape 4 days later when you're ready to use it. So keep them cold. Keeps things from breaking down. That's all going to be based off of your local protocol. So CPR, lay rescuers are now taught if they're unresponsive and they don't have any appearance that they have a pulse or circulation, immediate initiation of chest compressions, 30 at a time, or basically continuously. If they're unable to distinguish between those that have a pulse and who do not, people are not good at taking pulses, particularly lay rescuers who don't do this on a daily basis. So they said, just get on the chest, press on the chest until they start to spit and sputter and sit up and look at you, or somebody comes and takes over. So the carotid pulse. If the carotid pulse is not detected in 10 seconds, begin chest compressions. This is what we still do at the healthcare provider level. We are still checking pulses. There are many of EMTs who have a difficult time getting a carotid pulse, so pay attention to what I'm about to say. Put your fingers on your Adam's apple. Slowly pull your fingers towards the side of your neck. When you hit a little muscle there, you're going to have to put a little bit of pressure on it. When you hit a little muscle there, that's the groove between your Adam's apple and that muscle where you're going to find that carotid pulse. If you put your fingers on the side, and I hate this picture because it looks like you put your fingers on the side of it. If you put your fingers on the side, you're not directly touching that artery. That artery is behind that muscle. So putting the finger in the groove is where you're going to find that carotid artery. All right, so healthcare provider CPR, we're quickly checking a carotid pulse. We don't have a carotid pulse, we start on chest compressions. We'll go back to AB later. There's some advantage by responding in teams. We have multiple people can be doing multiple things. Somebody's pressing on the chest, somebody's checking the breathing, somebody's starting to get the AED. So by having teams available, multiple things can get done simultaneously. If we have to do it one person at a time, or one person doing the rescuing, it really slows the system down. So when we talk about cardiac arrest, there are a number of things that we refer to as the H's and T's, and those H's and T's are listed here. The paramedics, the doctors, the nurses, when they go to advanced cardiac life support, which is like CPR at the next level, we learn about H's and T's. So there's the H's and T's that are the potentially reversible causes of cardiac arrest. Hypoxia, the most common cause in pediatric patients, in fact, in many cases in adults as well. Hypoxia kind of becomes the second fiddle because it's actually a cardiac event, but it leads to hypoxia. So providing supplemental oxygen and ventilation is a potential treatment for that. Hypovolemia, in a patient with trauma, evidence of internal or external bleeding. Infuse IV fluids, because once the heart's running on half of the blood it normally should, it's kind of dry firing. Hypoglycemia can be a cause of cardiac arrest in diabetics. So if we have a patient, we can check a blood sugar. So if we're not sure whether or not they have a diabetic history, check a blood sugar. And if they have a low blood sugar and they're in cardiac arrest, give them some D50. And if we can give them some D50, then hopefully we can pull that sugar up, and maybe they'll respond to that. Hypothermia, hyperthermia. So if the environment is particularly hot, particularly cold, it can cause them to have cardiac arrest. Also suspected in septic patients. So you can do some rewarming or cooling of your patient. If they're in wet clothes and it's cold outside, you get the wet clothes off, you get them in a warm ambulance, cover them with blankets. Use warm IV fluids if you've got them. On the other end of things, they're hyperthermic. We do some measures to cool them down. We might use some misting with some cool water to help improve evaporation, crank up the air conditioning, cold packs in the soft spots. Hydrogen ion issues, which is acidosis, and acidosis is something that we're going to work on with oxygen and ventilation and adequate chest compression, because it removes those acids, takes the places of the acids, and so oxygenation is a easy thing for us to do to fix a couple of these things. Hypo or hyperkalemia, so high or low levels of potassium. It's fairly common in dialysis patients, some diabetics, patients who are on certain diuretics, people who take too many vitamins, dehydrated patients. So getting a good history can help here. Usually there's not a lot we can do for those patients other than some fluid. Fluid usually can be helpful to them. If we for some reason would believe they have hypokalemia, LR would be helpful. If we believe they have hyperkalemia, no LR, use saline, because that will help dilute it. But it's hard to know. The T's include trauma. So if we have some sort of a trauma, somebody gives us some history, depending on what that exact trauma is, if they have a gunshot wound to the heart, there's not much we can do about that. But if it's a trauma that's led to hypovolemia, sure, we've got something. Toxins, so overdoses, poisonings, and so on and so forth. Good scene size up. If it happens to be a toxin of opioid nature, a narcotic, Narcan could potentially be helpful to this patient. Thrombosis, which could be a stroke, and an ACS, a pulmonary embolism. We're going to assess it, try to determine it, but again, something we're not going to have a lot of ability to do much about. Pulmonary embolism, we could potentially give them some fluids. A tamponade, cardiac tamponade. This is suspected with penetrating injuries to the chest. It doesn't have to be penetrating, but in more times than not, it seems that it is. Also, patients with cancers and other severe illnesses, so not much we can do about that in EMS as well. And attention pneumothorax. This can occur from traumas and lung diseases. It requires an immediate decompression by paramedic or the hospital. So if you have ALS available, get ALS headed that way, which you should for all cardiac arrests. And the paramedic can pop a needle in their chest and let some of that air out. Otherwise, head for the hills. So our scene size up in our primary assessment for our cardiac arrest victims. There's a lot we can gain from taking a good look at the scene. If that patient's unresponsive, there's cyanotic mottled skin, we're going to need to get immediate resuscitation measures. As we have time, as we have hands, we can have people kind of doing a better look around the scene. We can be asking some more questions of the family members and bystanders. Cardiac arrest is not immediately apparent. Quickly then check for responsiveness, breathing, and a pulse. So walking into a scene, having an unresponsive person puts us into a quick work mode. If we get there and this person is cardiac arrest, no pulse, then we need to get on the chest. I did mention that if the patient arrested in front of us, so the patient had a pulse, and next thing we know the patient is pulseless and slumped over, it may be beneficial for us to apply the AED and shock them as soon as possible, simply for the fact that we know oxygen was just going around their body, and the heart shouldn't be terribly deprived yet. The reason that we, in most cases, start compressions before we do anything with the defibrillator is we want to get the heart a little bit of oxygen so it's a little more receptive to responding to defibrillation. So if they're unresponsive and they have apnea or agonal respirations, quickly check the carotid pulse. If you don't detect a carotid pulse within 10 seconds, then begin chest compressions. So once you've recognized an arrest, chest compressions have to be started immediately, and we need to sequence our patient care. Once we've identified the cardiac arrest, start with the CAB method, do circulation, then go back, work on the airway and the breathing. But again, remember what I said. If we have multiple responders that can be doing multiple things at a time, then use that to our advantage. Somebody's getting an AED, somebody's checking airway breathing, somebody's doing chest compressions. And if you've got enough hands, somebody else is getting a backboard to put this patient on, somebody's talking to the family, somebody's getting ready to take over compressions for the original compressor. It all depends on how many hands you have. Believe me though, there is a time in which there are too many people present, and some people just need to get kicked out. The chest compressions, we start with those now because we know that there's a certain amount of oxygen that is residual within the blood and in the lungs. It's not ideal, but it starts the process, and it starts getting some oxygen where it needs to go. No oxygen versus a little bit of oxygen. A little bit of oxygen is better than a sharp stick in the eye. So time taken to assess and establish the airway and begin breathing with a bag valve mask delays that circulation. It keeps us off the chest. It keeps that blood from going round and round. Chest compression creates a negative and a positive intrathoracic pressure, so it kind of works with that vacuum to alternately fill the heart with blood and then squeeze it into the circulation. So when the chest is re-expanding, it kind of creates a vacuum, sucks a little blood into the heart. When we then push down on the chest, it squeezes the heart and it pushes the blood out. Push hard and fast, at least 100 times per minute. So you can see the CPR resuscitation summary on 437 in your text. This class is not a CPR class. You should well know CPR. We are going to expect you to know CPR, so if you're not comfortable and familiar with it, it might be time to either A, get a refresher course, or B, spend a little time refreshing yourself and learning about it. If you need a CPR course, contact your community college and get that set up. And then limit your interruptions. If we can avoid being off the chest for any longer than 10 seconds or so, that's great. It doesn't take very long anymore to do analyze with the AED, nor does it take very long to deliver those shocks. So the less time we're off, the better. Definitely we want to spend no more than 30 seconds off the chest. But if we can limit it to closer to 10, and in many cases we can, do that. Just remember that the electricity, when you're doing an analysis, you touching the patient does create false electrical impulses. And when you are touching the patient, when you're delivering energy, the energy can be passed on to you, and it does pass on to you, and it will hurt, and it does have the potential to kill you. So our hand placement for adult chest compressions, remember, it's right in the center of the chest. In reality, we say you take your 2 fingers and you trace it up the ribs till you find the xiphoid process. Put your 2 fingers over the xiphoid process so you keep your hand off of it. It's the lower half of the sternum, so stay on the lower half of the sternum. Try to stay away from the xiphoid process. You're pushing on the xiphoid process, you're poking it into the liver, you're lacerating the liver, causing internal bleeding. So stay off of that. The other thing it does is it breaks off, and it's just a pain in the butt. So one provider starts with chest compression, the other prepares a defibrillator. If we have a third, they're working on airways and ventilations. If you're alone, you start with CPR until somebody else shows up. 100 compressions per minute in a pattern of 30 compressions followed by 2 ventilations until an advanced airway is placed. When a patient is intubated by the paramedics or the hospital staff, then usually they don't even stop compressions. It's just continuous compressions until until you either resuscitate the patient or you call it. When you have a king airway in or a combi tube in, there's not as much science that backs it up. But if you are good and you can ventilate between compressions, then you probably are going to have a much better time getting air in. The problem is when somebody's pressing down on the chest, it doesn't make it very receptive to receiving the oxygen. And since the combi tube and the king airway don't actually go into the respiratory tree, it's easier for you to actually have some issues with air leaking by some of those cuffs. So minimize your interruptions as much as possible, and I can't emphasize that enough. Mechanical CPR devices, they have 2 of them actually shown on page 439 in your text. The first one, A, the top picture, that is the AutoPulse, which is a product of the Zoll medical company, Zoll defibrillators. The bottom 2 there are the Lucas device, and those are products of Physio-Control, but they're automatic compressors. There's different types of devices out there. There, in fact, is a type out now that also has a ventilator built into it, so you don't even have to bag the patient as long as you have an advanced airway in. If you don't have an advanced airway in, you still have to do BVMs. But so if you're using these, know how to use these. Don't wait until you have to go on a call and need it to learn how the heck to do it. You should not be sitting there reading the instructions while you're trying to do this. So, and follow the manufacturer's instructions and adhere to your protocols. You have to have protocols to be able to use this thing, so follow those. So, open the airway and begin ventilations after 30 chest compressions. Hopefully you have somebody else there to help you, and we'll do 30 and 2. And with that 30, 5 to 8 compressions to get the blood pumping and get it up to pressure. And then beyond that, it is doing a great job of circulating the blood at about a 30% efficiency. So, and then the ventilations will help reoxygenate the blood. We used to do 15 and 2. It was 15 and 2 and 5 and 2, depending on what your ratio to rescuer was, and so on and so forth. And we did 15 and 2, and they found that we were losing ground because we got it, took that 5 to 8 compressions to get the blood up. We barely got it pumped anywhere before we stopped and gave a breath. So we now go with the 30 and 2, and that science is showing that has a better benefit. So with airways and ventilations, we're going to open the airway with the appropriate maneuver, whether it's a head tilt chin lift or a modified jaw thrust, depending on if they're medical or trauma. We're going to deliver the ventilations via a bag valve mask or a mouth to mask, and then deliver each ventilation over about 1 second using enough volume to start the chest rising. Once the chest starts to rise, that's as much as they need. You can stop pressing. It used to be people thought, oh, I have to get all of this air into them. An average adult bag valve mask holds about 1,600 mLs of air, and you really only need all of about 500 mLs of air to get the chest to start to rise, and that's sufficient to keep them oxygenated. Preferably, we have our bag valves hooked up to oxygen at about 10 to 15 liters per minute. Excuse me. There are a number of oxygen regulators out there now that will pump all the way up to 25, and in reality, most people do not need 25 liters per minute of O2. All you're doing is wasting it. So, in most cases, 15 liters hooked up to your bag valve mask with a reservoir, meaning the little poofy bag or the corrugated tube, is what you're going to need to give them a nice level of O2, close to 90%. So after your two compressions, you start after your two ventilations, you start compressions again. If the air does not enter despite the proper airway position, suspect foreign body airway obstruction. So usually, if it doesn't go in with the first breath, we reposition the head and try it again. If it doesn't go in with the second breath, we assume the foreign body airway obstruction. Usually, our chest compressions will help dislodge that. So, try another set of chest compressions, see if it forces the object out of the airway, and then pay attention when you go ahead. Look in that patient's mouth before you put the bag valve mask on. Is there anything in there that we need to sweep out? Don't forget we might need to suction this person. Don't forget we may need to put an oral airway in. And eventually we're probably going to want to put a king or a combi in. But you can start with something simple like a nasal or an oral, and your bag valve and some oxygen, some suction. Basic stuff works. So, here we go. Vomiting. Vomiting can occur. Vomiting almost always occurs, and make sure that we're ready to suction this person. So, with an advanced airway in place, you can do chest compressions continuously at 100 per minute. You may have some struggles with this, again, with the combi tube or the king airway. If that's the case, then just continue with your 30 and 2. Rotate providers performing chest compressions. A new person needs to get in there every 2 minutes to do chest compressions. I don't care how big of a stud, muscle builder, bodybuilder, muscle man this person on your department is. They get tired. And they've done studies, and they know that these people, even the big studs, get tired. So if they really want to be involved with chest compressions, kick them off every 2 minutes, switch. And maybe you have two people that are switching back and forth, but at least gives them 2 minutes to rest and get ready to go again. So over time, they've done plenty of studies and found that those people that really think, oh, I'm doing great chest compressions, they really aren't. After that 1 to 2 minutes of time, they're really starting to tire out. And so giving them a short break will help. So integrating an advanced airway device, combi tubes or supraglottic airways such as the King. The King airway is considered supraglottic. The combi tube is dual lumen. It can delay doing some chest compressions. It can delay doing ventilations. However, if you're fairly skilled at it, you've done some skill maintenance, gone to some Con Ed classes, in services, whatnot, you can do this pretty quickly. So if you're fairly skilled and comfortable at it, usually by the time that somebody's getting done ventilating, so it's compressions for 30, give 2 breaths, if that other person can be ready to slide in there and slam this tube down there, they've already checked it, they've already gotten all the equipment out, the suction's ready to go. If somebody's able to do that before you even get to the next, through the next 30 compressions, you're easily going to have that thing in place, and we'll be able to just check the lung sounds and the gut sounds at the next time that you give ventilations. So once it's in place, if you can, continue compressions continuously and don't interrupt. So the AED. Hopefully you guys are all familiar with the AED, but there's a video on using it. In cardiac arrest, defibrillation, early defib is critical for patients who have a ventricular pulseless rhythm like VFib or VTAC. Defibrillation does nothing for asystole. It actually stuns the heart. It does nothing for PEA. We talked about that one before. So those two rhythms are not affected by defibrillation. We are not restarting someone's heart with defibrillation. We are resetting it, hoping that it will start on its own. But to simply defibrillate somebody is not restarting. It is wiping out all the negative, ugly chaos going on and starting with a clean slate. That's what defibrillation, not defibrillation, defibrillation does. So early defibrillation is critical to hopefully getting the heart to beat in sequence again. So to maximize our successful defibrillation, got to keep our chest compression interruptions to a minimum. So like I said, if we can avoid being off the chest for more than 10 minutes, or I'm sorry, 10 seconds, we should do so. So we should be skilled in the way that this is placed. You don't have to stop compressions to put the pads on. Most people's chests are big enough. We can get the pads in the appropriate spots. We're not doing compressions over the pads, so we can do these compressions in the appropriate spots without interrupting the compressions. So we can have those on, we can have the machine turned on and ready to go, and then once we get to the end of that cycle, then we can perform that cycle of 2 minutes or 5 cycles of 30 and 2 compressions and breaths. Then we can analyze that patient and then follow really what the AED tells us. Most AEDs are very explicit in telling you what to do. Some of them are even, you hit the power button and then, as long as you can follow directions, it tells you everything to do. Place the pads, and there are diagrams. I mean, if we go back and we look at this, you can see right there on the pads and on the defibrillator itself, it shows you where exactly to stick the pads. A lot of them have just 2 buttons now. They have a power button and they have a deliver the energy button. Older ones had 3 buttons, 1 button for analyzing. Most of those have gone by the wayside now, so once you turn it on, it becomes no-brainer. VFib, we have thousands of electrical foci in the heart. So thousands of little cells are all just spouting off whenever they want. So it'd be like if we took a whole school full of, say, kindergartners, first graders, and preschool, gave them all a Jolt Cola, a pixie stick, and a puppy, what would happen? We would have mass chaos with all of these kids just going nuts. So if we somehow had a giant taser, and we can tase them all at the same time, that would be what defibrillation is like. So we tase them, we knock them all on their butts and say, okay, now listen, we want you guys all to do what you're supposed to do. Get in a line, let's go. That's defibrillation. So it's trying to knock this out. Never apply the AED to a patient with a pulse. It can be tricked, not to mention the pads are expensive. So don't put the AED on the patient with a pulse. If the patient is looking at you, they do not need the AED. If you have a monitor that's capable of putting the little patches on and the little wires to monitor their heart, and your physician medical director and protocol allows it, fine. That's okay. Do not put the AED pads on, because the AED can be tricked. It can shock them unnecessarily. Defibrillation does not restart the heart. It is an electrical current passed through the heart. It depolarizes all the cells together and hopefully gets them to work in the same system that they're used to. Manual defibrillation requires training in how to recognize the dysrhythmia, so you need to be able to interpret what you're shocking. The AED interprets it for you. It uses a computer algorithm that looks for patterns. It looks for patterns and it looks for heart rates. With manual defibrillation, sometimes we shock people that have a pulse because it's a special rhythm that we have found that we know needs something done immediately. The manual defib also allows us to change the energy levels where AEDs will automatically advance on their own. So that AED, it analyzes the rhythm. If it meets the certain criteria, it's going to say shock advised. If it doesn't meet the criteria, it says no shock advised. So it's going to tell us do or do not. They throw the S on the front of there, the SAED, semi-automated or semi-automated external defibrillator. But it tells, instead of delivering a shock, it's going to tell you that you need to push a shock button. Most of what we actually use are SAEDs. We use semi-automated external defibrillators. The very first versions of AEDs, the automated external defibrillator, it was you put the pads on, you turn the button on, and that was it. You didn't have to do anything else. Well, people who have implanted defibrillators still have those because if you have an implanted pacemaker defibrillator or a defibrillator on its own, it's going to analyze your heart constantly, and it, when necessary, deliver a shock. The problem with a fully automated AED for EMS is if we would have this person on our metal cot who is in cardiac arrest that we've been, maybe they haven't even been in cardiac arrest. Maybe they're on our cot, not in cardiac arrest. The AED just happens to analyze them and says, oh, they need shocked, and it starts to charge up, and you're halfway down a flight of stairs. Guess what's going to happen? It's going to get real ugly. Because all of you guys are going to go tumbling down the stairs because the patient who was touching the metal cot and the metal cot that you were touching then conveys that electricity onto you. So most of what we use now is actually semi-automated external defibrillators. All AEDs, all medical equipment require preventative maintenance. Your cot requires preventative maintenance. It has to be inspected, it has to be lubricated. Your blood pressure cuffs need maintenance. They need to make sure that they're within calibration. They need to make sure that they're not dry rotted. Your stethoscopes periodically need things done to them, like new ear tips put on them. So everything needs maintenance, AEDs included. AEDs run off of batteries, batteries die. So there's our typical defibrillator pad placement. There is an alternative to this. You can actually put one pad, you can sandwich the heart front and back. So one pad would actually be next to this patient's left nipple, between the nipple and the sternum, and then the other pad would be on the back in the same position. So between the left shoulder blade and the spine, and that sandwiches the heart. That is an alternative placement. It's not convenient, so that's why we use this one. This is called anterior placement. You occasionally will hear about anterior-posterior placement, so one on the front, one on the back. Keys in placing your defib pads. Number one, you want to have one on each side of the heart when possible. You're trying to pass electricity through the heart. If we had them very close together, the electricity follows the path of least resistance, so it might only go through the skin instead of going through the heart. When they're sandwiched like that, as far, kind of as far apart as possible, the electricity has to flow deeper than just the skin. So if the pads are touching, you're going to get no electricity to pass through the body anyway, and it's just going to go pad to pad because it's trying to complete the circuit. So make sure you don't have anything underneath the pads. If you have like a nitro patch and you defibrillate the patient, you're going to catch the patient on fire. Those things will burn. Metal necklaces, bras, that sort of thing. Make sure those are not in the way. It's got to be on the bare chest. Okay, so with your defib, check it regularly. Many of these will have little indicator lights on them that say, self-check, okay, or maintenance needed. Replace the batteries as specified. You need to read your owner's manuals to know how often you need to change batteries. And defib pads, replace them before they expire. Pay attention to those. I would not, if you run 10 calls a year, I would not go out and buy a case of defib pads. I would go and buy one set of defib pads, and then or actually two, one to use and one as a backup, because they are expensive and they don't have very long shelf lives. So if you buy a case of a dozen sets of defib pads, you run 10 calls a year, you're not going to use those except maybe once or twice in a year's time. And next thing you know, you're throwing out 8 or 10 packages of defib pads at $70 a pop. So pay attention to those things when you do your regular truck checks. The AED is only applied to patients in cardiac arrest that are unresponsive, pulseless, and apneic. And if the AED is available, apply and use it quickly with little interruption to the chest. So chest compression's got to keep going. If you witness them, then shock soon. If you haven't witnessed the arrest, get 2 minutes of CPR in. So to follow your local protocol, for instances where CPR started or continued prior to defibrillation. So if your protocol says if you witness the patient arrest, apply the defibrillator and shock immediately. The defibrillator has adhesive and conductive properties. Those pads are supposed to be sticky. And make sure you don't get anything in between them. So make sure that the pad is placed under the breast tissue when possible. Usually it may not be fun to have to move a particularly large breast out of the way, but we need this as close to the rib cage as possible. We don't want to have more padding per se. We don't want more padding between the pads. So as close to the rib cage as possible. So we may need to go under, move that left pad down a little bit. The right pad should be well above the breast. If they're extremely hairy, shave their chest. You should have little disposable razors in your kit. Shave the chest. Don't place it over jewelry or patches. Do not place it over internally implanted pacemakers or defibrillators. There's an example of a patient with both an AED, a pacemaker on the top picture of 442, and then the little kid in the bottom picture there, he actually has his AICD, which is a defibrillator. His is placed in his belly. You can see it just up above his belly button, off to his left, just a hair. So those bulges are pacemaker on the top and AED or AICD on the bottom. The top one is a little harder to determine where that's actually at, but it's on the left shoulder, just underneath the collarbone. That's the most common placement for standalone pacemakers, particularly in the adult population. People with AICDs or smaller people, they'll be placed down in the belly. So if they have that pacemaker or defibrillator, it's okay to shock them. We just don't want to deliver electricity directly over them because it can damage the device, cause it to go into kind of haywire mode. AEDs are pre-programmed to deliver shocks at certain levels. There is some ability for your service to switch this a little bit. There's a little bit of flexibility based off of what your medical director wants, but this is not something you generally can do in the field. It's something that you're going to have to take it in the office and either have it hooked up to your computer or use some other devices to change kind of the settings on it. Newer AEDs and manual defibrillators deliver what's called biphasic energy, and older ones do monophasic energy. Here's the difference. It is the way that it clears the heart out. So monophasic went from top to bottom. Biphasic goes from top to bottom and bottom back to top. So basically, like if I slapped you in the face, on the way by, smacked you on one cheek, that's monophasic. If I smacked you and then brought my hand back and backhanded you, that's biphasic. So that's the difference between the two. Biphasic is much more efficient, does a better job at a lower energy rate, so it's not as intrusive to the heart. So it clears the heart out, and hopefully it doesn't stun it quite as much. All right, so attach the AED pads. Apply that to the patient's chest, stop the chest compressions, clear the personnel before allowing the machine to detect and analyze cardiac rhythm. So in most cases, as we have gotten a minute or two, or a minute, 90 seconds into the process, if we can be slapping on the pads about that time and then hitting power button so it's ready to analyze really right there, that 2-minute mark, that's perfect. And it's probably, if it detects any movement, most of the time it will tell you, but it's not 100% accurate. So once it says analyzing, stand clear, that is when you need to get off the chest, because that's what it's really looking for, the electricity. So clear the patient, allow that machine to work. So here they're doing, if the patient's apparently unresponsive, not breathing, check the carotid pulse for no more than 10 seconds. You do not detect a carotid pulse within 10 seconds, begin chest compressions. Second EMS provider can get the AED prepared while the compressions are being performed at 30 to 2. If necessary, shave any excess hair, move any excess clothing that are in the way. Make sure that the AED pads get good placement. Apply the pads as directed by the manufacturer, usually up towards the right shoulder and down below the left, on the left side, below the nipple. And then, yep. Talking about pad placement. Turn on the defibrillator. It does a quick self-check. Most of the time, if you turn it on within about 10-15 seconds, it's ready to analyze, provided that you have the pads applied. If you want to keep it from going into analyze mode, don't plug the pads in until you're ready at the end of that 2 minutes. It'll beep and squeal and scream at you, but it won't do an analyzation. Once you plug the pads in and they're applied to the patient's bare chest and the power is on, within 15 seconds or so, it's ready to analyze. So once it says analyzing now, stand clear, you stop CPR. Hopefully it's right about that 2-minute mark. Keep everybody from touching the patient, and then let it do its analysis. Usually takes about 10 seconds or so. And then depending on the configuration, it may take a little longer. Most of the time it's going to tell you shock advised or no shock advised. You're going to push the button to deliver the energy. If it takes a little while for it to charge, and it usually makes a loud, annoying tone while it's charging up, then if it takes a while for it and your defibrillator doesn't shock within 10 seconds or so, get back on the chest and push on the chest. If it is a fully automated defibrillator, it will deliver the shock when it wants to. If it is a semi-automated, it makes you push the button to deliver the shock. Remember, when it says stand clear, shocking or delivering energy or whatever the machine says, that no one is touching the patient. Preferably, there's no oxygen being flowed over the patient either. So if you're bagging the patient without a king or a combi in, you make sure you point the mask away from the patient. Electricity, oxygen, it helps. The oxygen could help the burning process if necessary or if it happened, but not very common, but better safe than sorry. If you have the patient on a combi tube or a king airway, unhook your bag from it and hold it away. So as soon as that shock is delivered, back on the chest. We're not looking at screens, we're not checking pulses, it's get back on the chest. So if the defibrillation is successful, the cardiac output that they have for the first minute or two is not going to be enough, so the CPR kind of buys some time until the heart builds back up a little strength, kind of primes up again, and it starts working well on its own. So it doesn't matter if we immediately got a pulse back. The pulse is going to be so weak and so crappy that we're going to go with compressions for that 2-minute cycle. And then after 5 cycles of CPR, or 2 minutes of CPR, ending with 30 compressions, we're going to reanalyze. The machine is going to probably count this down for us, so it's going to keep us on our toes to do high-quality pressure or high-quality compressions and ventilations. Again, if it says shock advised, deliver another shock. If there's no shock advised, then resume CPR. If it says no shock advised, check for pulse, and you find a pulse, great. We don't have to do chest compressions anymore. But that's going to be after it analyzes. So signs of ROSC, which is return of spontaneous circulation. They start breathing on their own. They start responding to stimuli, including you pressing on their chest, telling you, hey, stop it. Or you now have a carotid pulse when we stop chest compressions. People who are not actively compressing, say the ventilator person, can have their fingers on that patient's pulse. And by monitoring the patient's pulse, many times they can say, hey, I can feel a good pulse while you're doing chest compressions. That tells you you're doing high quality chest compressions. If you stop doing chest compressions and they detect a pulse, hey, cool, we've got return of spontaneous circulation. We may also want to use capnography. Now remember the jury is still kind of out on whether capnography from a King or a combi tube is quite as accurate. It can't hurt, but it may not be quite as accurate as possible. But oftentimes when we have patients who have an advanced airway in and we're monitoring their end tidal CO2, we'll see that kind of hover around 10 or 15 each time that we breathe for the patient. And when the patient gets a return of spontaneous circulation, we see it start to shoot up to 30 or 40, or sometimes even more than that. So that could be a good indicator that, hey, we have a patient who's going to have a pulse return. And the pulse may not have returned yet. It might be predictive by watching the CO2. So in defibrillation, if we're using an older monophasic monitor, we're going to usually shock them at 360 joules. It used to work its way up 200, 300, 360. Some of them got switched over to just constantly do 360. And then the newer biphasic monitors sometimes are starting down as low as 120 and working their way up to 200 joules. And a lot of times they'll just automatically advance on their own. If the person is in contact with the patient, directly or indirectly, the electricity can be conducted to them. I told you that. And always instruct all personnel to clear the patient. Not only instruct them, but if you're the one pushing the button, you better be looking around to make sure nobody's touching. Defibrillation, do not defibrillate in a moving ambulance. Do not analyze in a moving ambulance. It can be fooled. Do not defibrillate in an environment with a combustible substance. So if for some reason you're in a silo doing chest compressions on somebody and there's some very flammable gases that occur in a lot of agricultural communities or areas, that if you would then spark this person up, and if you've ever been around a person who got defibrillated with manual paddles that they didn't use the gel, it stinks. And even sometimes with the pads, it stinks. So you can spark up a pretty nice explosion or fire in a combustible area. And then wet conditions. If the patient is wet, if the patient is laying in a pool, maybe they're laying in the kiddie pool, do not spark them up. You will spark up everybody that's in that pool with them. And if they're wet, get them out of the wet environment. Move them to a dry place and dry them off with a towel. So a lot of places in their AED kits, they have like a hand towel or a wash rag, a dry wash rag, a razor or two in case they would run into one of these situations. So a hairy person, they can shave them quick. Wet person, they can dry them off quick. So IV access and medications in the cardiac arrest patient. We're getting closer to the end here, kids. So IV access, CPR, defibrillation, airways, ventilations, those all take precedence over IVs and medications. So if you have gotten everything else accomplished, you have enough hands, you have the appropriate resources, and somebody is able to allow you to start an IV, then do so. You can establish it only when an AEMT or paramedic is present, and only when it's not going to delay what we're working on. So if we are, say, on our way to the hospital and we don't have anything to do right now, somebody's doing compressions, somebody's doing ventilations, you've got a second, you can get an IV in, great. maybe you're going to put an IO in. You can use an IO. Works a lot of places. Real quickly, we'll jump to IO and cardiac arrest. I would prefer an IV over an IO, but if that's what your protocol says, then you need to follow protocol. Resuscitation outcomes and post-resuscitation care. If that patient had a return of spontaneous circulation, the greater chances of them being discharged neurologically intact is when we do some post-resuscitation care. It is a code save when that patient is discharged from the hospital neurologically intact. It is not a save when you deliver them to the hospital with a pulse, because if all you did was now make them a vegetable, that's not really a save. That people want to count that as a save. It's not a save. A save is when the person walks out on their own and they have no deficit, or they have minimal deficit. Most cardiac arrests are unsuccessful. They say most out-of-hospital attempts are unsuccessful. Most cardiac arrests die, period. We save 3% of the cardiac arrest patients. So it's not great. Slowly we are improving as we use more science, and we're doing better chest compressions, and we're making sure we're staying on the chest, and so on and so forth. It's slowly improving. Some places are now able to boast a 10 or a 15% save rate, which is fantastic. But it takes practice, it takes work, it takes studies, it takes trying to build a successful system, not just showing up from time to time. So the resuscitation outcomes, with all the links to the chain of survival in place and functioning, 50% of cardiac arrest patients could be resuscitated, not are resuscitated. So there are some places that are really getting close to that 50% mark because they've done fantastic things building out-of-hospital response teams, training their public in CPR, making sure there's AEDs available, optimizing the way that their systems work. It's possible. So every community needs to have continuous quality improvement. You need to constantly look and to say, how can we do better? So touch on a special topic here, the infants and children. Most pediatric patients, their heart is in good shape. The reason they arrest is from hypoxia, so they had a respiratory issue that went bad. Frequent cause is an airway or breathing issue, so they had an asthma attack, a severe epiglottitis, something along those lines that's caused their airway and breathing to collapse on them. Additionally, things could be like foreign body airway obstruction or choking, asthma, respiratory infection, drowning, electrocution, overdose, trauma, and survival rates are improved with bystander CPR everywhere, not just in infants and children. So the sequence begins again with chest compressions. Lone rescuer compression ratio is 30 to 2. Two rescuer ratio is 15 to 2. And it's very likelihood, the likelihood is that they have an asphyxial cardiac arrest. So we kick up the rate of respirations in those little guys simply for the fact that they need more O2, and the more likely cause of their arrest is from a lack of oxygen. The compression rate is at least 100 per minute. An infant is classified as under 1 year of age, and a child is now until they've hit puberty. Old school folks know that used to be until they turned 8, but now that has changed until they have reached puberty. So the beginning of breast development in girls, or the presence of armpit hair in boys, is what they kind of use as their real quick guesstimation of when you go from child CPR to adult CPR. Checking the brachial pulse in an infant, remember that occurs in the arm between the bicep and the tricep. And the way that we typically will position our fingers, this is the most efficient way to do this, and it will tire you out the least to do it this way. You encircle the baby with your hands, put your thumbs right together, right at the nipple line or just below the nipple line there, and you do your compressions that way. And you're going to compress for roughly a third to a half the depth of their chest. And that's true with all the cases. That's a third to a half the depth of their chest, which we used to go by inches and say that, you know, an infant was a half to 1 inch, a child was 1 to 1.5 inches, and an adult was 1.5 to 2 inches. But it's really based off the size of the person. So 1/3 to 1/2 the depth. Hand placement: one hand on a child's lower half of their sternum. Try to stay off the xiphoid process. And then the infants, of course, the 2 fingers placed over the sternum or an encircling. And then try not to interrupt compressions for ventilations again. In infants, children, and in adults for that matter, we see a lot of gastric distension from ventilation. So chest compressions used when the heart rate is less than 60 per minute and with signs of poor perfusion in the infant population more so. When we have that really low heart rate, we're trying to boost it up by giving some extra chest compressions. So secondary assessment and history taking when we're doing a cardiac arrest, not just in children, in general. When we're doing that, we're looking for any rapid interventions that we can do for our cardiac arrest. We do a quick medical assessment on the patient, a quick once-over head to toe, not inch by inch, but a quick once-over to look at all the major body parts, see if anything stands out, and then try to obtain as much history from the family or bystanders as possible. Remember, we may also have to kind of do a little snooping if we have extra hands. So knowing the events that preceded that cardiac arrest can help us identify certain things like toxins or traumas. We go back to the H's and T's again. I'm not going to dwell on this because we've already talked about this. Ethical and legal considerations. When your protocol allows it, you may be able to pronounce a person dead in the field. You may not have to transport them all the way to the hospital. Depends on what the protocol is. It is legal in most states for you to discontinue CPR with the approval of medical control. Do not initiate resuscitation on those that have signs of obvious death. Rigor mortis, dependent lividity, the decomposition, injuries incompatible with life. If you have a do not resuscitate order, you need to have some sort of a protocol that gives you some recommendations of how to manage that. So if the person shows up, hey, I have a DNR, here's my dad's do not resuscitate or do not attempt resuscitation order, then you can hopefully withhold those efforts. And then look after the well-being of the bystanders and the family members. We kind of switch from being rescuer to counselor and have to do a little bit more family care there. Maybe we're calling and asking, is there anybody we can have come in to help you in your time of need? And then contact your coroner, your medical examiner, depending on how your system is designed. If for some reason we get return of spontaneous circulation, we're going to want to monitor the heck out of that patient. Once they get a pulse back, we go back to doing things like checking blood pressures, checking pulses every 5 minutes or less, constantly if possible. If that pulse fades away, then we have to start back the cardiac arrest again. Start our defibrillation protocols. If the blood pressure remains really low, we might want to try to give them a little bit of fluid. We might also want to let the paramedics know or the ER know. They might want to start that drug dopamine. Can be very beneficial for these people. I talked a little bit about therapeutic hypothermia. The things that we can really do, not much in most cases yet. It's still becoming kind of a bigger, better thing. But if we can do some cold fluids, we can put some ice packs in the groins and the pit and around the neck. There are other things that some other systems may have in place. Therapeutic hypothermia is going to continue to grow, I believe, and we're going to. They're seeing very good results when we have therapeutic hypothermia. So if that patient doesn't immediately wake up when you resuscitate them, they're generally a candidate for this. So that goes with your think about it again. So in summary, long chapter. AEMTs, we have to rapidly identify those patients that are shock and cardiac arrest patients. We have to take immediate actions in order to start resuscitation. It's going to improve their chances of survival. Our goal is to quickly restore their perfusion. And in shock, our priorities are established: airway, ensure the patient is adequately ventilated and oxygenated, and then controlling bleeding. In cardiac arrest, we're going to establish chest compressions immediately, work towards airway breathing and defibrillation. And defibrillation is required for certain cardiac dysrhythmias such as VFib and VTAC. So establish an airway, provide ventilation, high-quality ventilation, high-quality chest compressions. Compressions constantly if we don't have to stop for some reason. In both cardiac arrest and shock, it requires a lot of teamwork in order for us to be efficient in the way we do this. We've got to be able to communicate with one another, with the hospitals, with additional responding units, and search for that underlying cause. And for all critically ill patients, apply clinical reasoning to determine what the heck's going on and where's the next step. And to continue to provide patients with the best opportunity for survival, you need to maintain your awareness of current research and protocols. So going to continuing ed classes, going to your in-services, reading articles, all these things help you stay on top of things because this science changes, and it changes on a regular basis. So it's something you need to pay attention to. Cardiac arrest science changes at a minimum once every 5 years. The American Heart Association every 5 years publishes new science that helps guide us in the next 5 years worth of patient care. So things will change over time.